Good afternoon. Thank you, and I'm excited to be the first speaker here in the nursing session that you guys have got this going. And I was actually born at St. Mary's and went to John Abbott and then moved to Ottawa. So coming home. Okay, so I'm going to talk to you. I've been asked to talk to you a bit about CAR T and bispecific therapy, giving it a nursing perspective. And these are my disclosures, and I'm very honored to share my nursing experience with you guys today. First, I would like to make a land acknowledgement. I wish to acknowledge the beautiful land, water, and sky which we are residing in. I'm grateful to the First Nations, Inuit, and Métis persons whose traditional territories we are on as we continue to strive and support reconciliation. So today I'm going to talk a little bit about CAR T therapy, enhance your knowledge of potential acute complications of CAR T therapy through some patient case discussions, talk about your bispecific T cell engagers, enhance your knowledge of complications of these therapies through patient discussions, and provide an overview of management strategies, and discuss some advantages and disadvantages of both therapies. Now, I just want to know, show of hands, how many people work with CAR T therapy presently? Okay, so we got a couple here, good, that have some experience, great. So the CAR T is the chimeric antigen receptor genetically modified T cells that are designed to recognize specific antigens on tumor cells, resulting in their activation and proliferation, eventually resulting in significant and durable destruction of malignant cells. CAR T cells are considered a living drug since they tend to persist for a long period of time, because again, we're activating that immune system, creating T cell memory. The design, it's this chimeric made up of different sources, the antigen specific for specific targets, like on the B cell malignancies, the CD19 with our lymphomas, and now BCMA with multiple myeloma. The receptors expressed on the cell surface engineered to recognize the antigens, and T cells are the type of lymphocytes. So very important, they use a viral vector. They've got co-stimulatory domains, again, depending on what the source is they're looking to attack. And the signaling cascade that allows the CAR Ts to expand and persist, which are really important parameters for success. So the process, so depending where you're working, it's the referral, right? So in my center, we're a big center. We do about 50 CAR T infusions a year. So we have a lot of internal referrals, but then we get patients from the rest of the province. And initially we were supporting a lot of people across Canada. We still do CAR T for Newfoundland, some for New Brunswick, and some other centers, depending on volumes that we do quite a few. So the referral is important. The time to referral is important. The process itself is a little different than our other autologous transplants in that we don't give GCSF for collection. It's just your unmodified T cells. They'll do the leukapheresis, take them, then they'll go to a pharmaceutical lab where they'll be injected with a viral vector. They'll grow and replicate. They'll remove the viral vector. They cryopreserve them, freeze them, and then ship them back to our centers. Right now, most of these centers are in the States, so we wait until they come back to our center. And then we give them a little bit of chemotherapy. So we want to do just a little bit of lymphodepleting to make a good environment for these transplanted cells. Defrost and infuse. So in Canada, these are all the products that are now approved. And again, most of them have been for your lymphoma type diseases, your B cell malignancies. Recently, Health Canada has improved multiple myeloma CAR Ts, but there's a dispute about the funding. CAR T is very expensive, right? The regular products are about $500,000 just for the product itself. Right now, the multiple myeloma ones are coming in at $750,000 just for the product. So that's where Health Canada, we're a publicly funded healthcare system, right? And multiple myeloma, there's lots of different treatments. So it's going to be figuring this out and getting it, but I'm sure we will be seeing it eventually in our areas. So let's talk about some toxicities. So the cytokine release. So I took this from ONS, but it's that systemic, and we heard a little bit about it this morning, and I'm sure everyone's getting up on all of this, but systemic inflammatory response triggered by infections in certain drugs where a large number of lymphocytes and or myeloid cells are activated, leading to the rapid release of a large number of inflammatory cytokines. The incidence can vary widely depending on the type of cancer, the therapy that's used, and the diagnosis. So the interesting thing with your CAR T and your other products, this cytokine reaction, and Dr. Shabat alluded to that a bit, is that we can see this total systemic response that can happen. Most patients, it's a mild flu-like, sorry, I have my asthma, it's bad. That mild flu-like symptoms with the fever, but we can have some patients where there'll be life-threatening complication, that capillary leak, multi-organ failure. So everything that we use is related to CAR T now, as Dr. Shapat talked about with the bispecifics. So we were quite fortunate. There was first the studies with Lee and Penn State, and they then came together with some consensus grading. Fever is the number one reaction you're going to see. And it's a high fever, 39, 40 degrees that a patient will have after CAR T. Then we can see some hypoxia and hypotension. So there is a really helpful tool. There is an app. There's the CARTOX app that you can use that goes on your grading and your management. So just looking at some of the products we commonly use, for our diffuse large B cell, we see the Yescarta. So again, 93% will have a grade 1. It's usually within a couple days. And again, related to the disease burden, okay, puts you at higher risk for having that inflammatory reaction. The other thing is important. Patients shouldn't have an infection. If there's already an inflammatory reaction going on, we sometimes will delay the infusion until we've treated and managed that, because again, we've already got an inflammatory process going on that's going to add when we infuse the CAR T cells. So usually it's about 2 days, and duration can be, and again, just showing you, highlighting the symptoms, mainly fever. We see some hypotension with all of these. And then same thing, the Kymriah is not, we don't use as often anymore. It's more in third line for lymphoma, but it is proved in ALL for your patients 25 and under, and high incidence there of fever that you will see it. The Breyanzi is a newer product that we are seeing now. It's quite interesting for us because I don't know if you saw on the first slide where I had the picture, most CAR T products come to us in a bag. They're clear to a slightly color with yellow, and we infuse them like we do. We infuse all our products via IV pump, but the Breyanzi product will come in vials. And the nurse, we have to draw up, there's going to be vials of CD8 and CD4 that we have to draw up and infuse. So that's added to definitely to my workload and my nightmare for administration. But the nice thing about Breyanzi is that there's less CRS and ICANS. So it takes longer to develop. So there's different things. So you'll see as to what, we're always debating why does a physician choose one or the other? Sometimes it's booking to get a slot in the company to get your cells manufactured. Sometimes it's looking at the patient when they're choosing what type. So at our center, we've taken the AST guidelines and we've made a nice table, as I'm sure most centers have, as to how you manage it. And the really nice thing that I like with the grade 1, when we have a fever, we're going to do our septic workup. we start prophylactic antibiotics. You'll see most of the time your septic workup will grow nothing because it's related to the cytokine reaction. It's not an infectious process. We'll give them Tylenol, of course, after you've checked the temperature. See, someone else knows I stay. But the nice thing here is that we do bring in medications to calm down that inflammatory reaction. They talk about giving tocilizumab if you've had a fever for like 3 days. And I find it's challenging as a nurse. Sometimes each physician will be different on when they pull the trigger to give the toci. So your nurses, we have no consistency in that. But you will see that. But it's nice because if you've had a temperature of 39 or 40 for a couple of days, you feel pretty rotten. And then again, when we go to a grade 2, that's when we're seeing either hypoxia or hypotension. So tocilizumab is a humanized monoclonal antibody that blocks the binding of IL-6 receptor. It's given over 60 minutes, can be given every 8 hours. We usually give it and then wait to see. Usually you'll see resolution of the symptoms within 24 hours. Normalization of your BP and your fever. It's about $2,000 dosing. So we always just give, where my physicians at first called their buddy in the States and everyone got Q8, the 3 doses. This is part of why, with the acute complications of CAR T, as to why it's done in transplant centers. Initially, and it's all, we have to be FACT accredited and all of this because of the black box warning with regards to your CAR T products. So this is part of it. So what we've done, we treat it as an oncology emergency like we would febrile neutropenia. Time to drug for us is an hour. Okay. And what we've done is now we actually have it in the fridge on the unit. We don't wait for pharmacy to mix it. Pharmacy would like us to have them see it to approve it, but we don't wait for them to mix it. We get the order, we're preparing it, and we're giving it. Okay. Something else that's a little different when you're giving some of these products is some of the blood work that they'll be monitoring. So here we're looking at your inflammatory markers, your CRP and your ferritin. So your CRP will rise more initially when you have that inflammatory reaction going on, and the ferritin will also, it's sort of a later, your liver. I thought I'd see my notes, but I don't. So that it will be something. So some of the docs, I don't know how acutely they watch it, but it is something that we're looking at and watching and looking at their reaction with the patient. And you will see patients with quite high results with this, with the inflammatory response going on. The other one is that immune effector cell-associated encephalopathy. Signs and symptoms, we have that decreased attention, disorientation, encephalopathy, anxiety, confusion, delirium, language disturbance, somnolence, ataxia, weakness, seizures, and they're uncertain. But I know initially, when in the CAR T trials and studies on mice and things like that, they did see that it did cross that blood-brain barrier. So one of the things is important too, when someone's going for CAR T, they want to make sure you don't have any CNS disease involvement, because it does cross the blood-brain barrier and will have that inflammatory response. Again, depending on the product, we see it usually about 5 days. It can range. It's usually reversible. We used to start everyone on anticonvulsants day 0. Now we do it a little differently depending on the product. So what we do is we'll start them on Keppra if it's your Yescarta, your Tecartus type of thing, or someone that's deemed high risk, that will start at day 0. But we used to start at day 0 and give it for 30 days for everybody. Now we've sort of changed it as we've gotten more experience, more comfortable with things, and looking at patients' risk and the product itself that you're giving as to what the risk is, and only prophylacting patients that would be at higher risk based on the product. Some studies, so there was some Zuma trials where they're trying prophylactic Decadron. giving it day 0, 1, and 2. My physicians haven't really gone into that quite often. They do for some, but it's not something that we do routinely yet. So when we're looking at it, we're doing that assessment. Okay, we're doing an ICE score. So basic assessment. Initially, my docs were like, oh, when we started Cartio, it was, the docs had to do it. Well, no, the nurse is there 24/7. And so they quickly realized we were better at doing it and did it consistently. So just basic orientation, right? And naming objects. And I'm quite tough when it comes to doing an ICE score. Like if you hesitate, I give you a 0. Like, there's no if and buts. Even my neurologist is nicer than I am. And I'm like, no, so it's really important. One of the, during COVID, as I'm sure with you guys, it was a harder time for that assessment because sometimes the family would say, oh, they're off, right? There's something not right. That dysgraphia, that writing. So we do that writing. We don't enforce a specific sentence. We make patients come up with their sentence. Just tell them not to make it a really long sentence because they'll hate us by the end of it. And sometimes it's fun, the sentences that they write. If there's any change in their ICE assessment, then we go to Q6 and we inform the doctor. Okay. So that we're looking at that. So again, depending on the products, your Yescarta is higher overall into Cardis. They're slightly higher than others. And then I just put in the slides. I'm hoping you guys get the slides after. What do we see? That encephalopathy, the headache, the tremor, depending on the product. And usually most will resolve. And as I said, the Brenzi looking at it's only 32%. So it's much less that you can see it in that product. So there's an example of one of our patients' ICE score. So he had bought a ticket for a lotto in his local community to win a car, a Charger. And so over time, you could see the changes in his writing. Okay. Sometimes it's challenging with a patient, right? What if you can't, we had a patient that came in with already aphasia issues. So how do you grade them? And I have some other resources on looking at your patient doing that. So again, we've adapted the AST guidelines into management. When I started with CAR-T, you would never give Decadron. They thought at first Decadron would diminish the effect of the CAR. And, you had to only call the staff person if there was anyone getting into trouble. But they've realized now steroids do not stop the CAR action. So there's, they will give, but they try to limit the steroids. So we'll give a dose and then we'll wait and reevaluate. And then we like to wean them rather quickly off of their steroids. We're quite fortunate at my center. Our neurologist loves CAR-T. And because most of our neurology is at our other campus, so she's sort of the lone wolf on our units and that. And so she's very involved with our patient population. She's even doing neurofilament testing to see if there's anything related there with the inflammatory action. So we'll see what comes out of that. There is a really rare complication of cerebral edema. It's only seen in about 1% of patients. You can see it probably a little more with patients with CRS, and they talked about ALL. We had a young patient. It was quite sad. He came to us from another center that does CAR-T, so I don't know if they refused him, but he was 31, had stage 4 diffuse large B cell, got his CAR. So he had a bit of CRS on day 5. Morning assessment, he was fine. 8:30, the nurse went in. He was unresponsive, seizuring. Luckily, on a Saturday morning, my neurologist was on the floor. So Ativan, seizure medication, transferred to ICU. He was intubated, got high-dose steroids, Toci, Keppra, Propofol, Midaz infusion for seizure suppression. The next day, his pupils were fixed and dilated. Stat CT was done. He had diffuse cerebral edema, was transferred to neuro. He crashed, he was resuscitated, went to the OR, but by day 7, he was confirmed brain dead and was removed from life support. So luckily, as I said, I do 50 a year. I've seen this once. It's a very rare complication, but young patients, this stays with you. There is another weird complication that you can see, this macrophage lymphohistiocytosis or activation syndrome. It is potentially fatal response to malfunction of the immune system, resulting in widespread inflammation and end organ damage. Again, it's a rare complication characterized by pancytopenia, liver insufficiency, coagulopathy, neurological symptoms. It's thought to be caused by a hyperactivation and uncontrolled proliferation of T lymphocytes, as well as differentiation of macrophages, leading to widespread hemophagocytosis and cytokine overproduction. Can accompany severe CRS and is associated with low fibrogen, high ferritin levels, DIC, and hemophagocytosis. I've seen this a couple of times, and again, it's your patient that has severe CRS that you might see this. So if they suspect it, we're going to be monitoring the labs. We're going to be looking at anakinra versus your tocilizumab here. We had one lady, it was very unfortunate. She actually, ended up in ICU for a bit of time, came up to the floor. They had done a PET. She was responded to the CAR, but this had shut down her blood system. And she passed away related to these complications and her lymphoma was in remission. So it was a hard, but again, I have one that sticks out in my mind, but that. The other thing that we have to think about, these people are relapse refractory. So tumor lysis is a problem so some of my patients will be on allopurinol. You're going to be, just doing daily. We're not as hyper as in my lymphoma side, but you're going to be monitoring your blood work, daily hydration. It's not a big issue, but it is a potential thing that we have to see. The other thing, I've had to add chest tubes to my transplant unit, because these patients, again, being relapse refractory, I have some patients landing from other centers to us that have pleural effusion. This is a list. We've made a nice table of the medications we use to manage the acute complications with regards to it and why you're using it, what it's for, what's the dosing. So tocilizumab, we will give maximum 3 doses, and then you'd say you're sort of not responding to that IL-6, that inflammatory responder. So that's when we're going to look at anakinra. We usually give it actually off-label as a sub-Q. What we do, on rare cases, I've had 2 patients where we've actually shut down the CAR. There's been such an inflammatory reaction. One patient, I actually gave the cells in ICU. He was so sick that I gave the cells in ICU, but the reaction, because he had so much tumor burden, was so significant. And then we had a young ALL that had such a reaction that we would give chemo to shut off the CAR to etoposide. Okay, but luckily those are very rare that we see. Other things we can see for our later toxicities, again, infection's a problem. I'll talk a little bit about that hypergammaglobulinemia and other things that you can see. So the cytopenias that we can see, it's well recognized, can last for months. Approximately 30% at day 28 will still have ongoing cytopenias, but only 10% at that 3-month mark. They don't really know what causes it. It might be related to that disease burden. Again, initially, CAR T for lymphomas was seen in 3rd line. So patients have had different treatments. In 2nd line, I've noticed sometimes when I've looked at patient cases, they have already recovered their counts earlier because we haven't treated them so much. But it varies. Again, the age of your patient, the disease, the burden, different things like that can affect how much CRS they've had. The CAR activity. So you used to think, I know when I first started, the ALL population thought, oh, if they still had some issues that it was related to CAR. More when I talk about the hypogammaglobulinemia, you can see that. You can see sometimes they might use GCSF. Lots of times they don't want to, in the literature, they talk about not using GCSF until the patient has gone through that CRS period. Once they feel they're free from the CRS, they might consider, and more in our patient population, I'm seeing it just if we've had ongoing issues with cytopenia, that we might use GCSF, you know, or other factors to bring up. I've had one patient with ongoing low platelets that we would see end plate or things or EPO. They'll have blood work every 2 weeks initially for the next 3 months. And then based on the patient's blood work, the monitoring will continue. I'm very fortunate. We have a nurse practitioner that follows all our CAR T patients. And that's just an example of your GCSF order. So infections, again, our patients, my world is hematology, so are always at risk of bacterial, fungal, and viral infections. So they're going to continue on prophylactic medication. So they're usually on something like acyclovir for a year, Septra for 6 to 12 months. Bacterial prophylaxis will depend where you're working. We use fluconazole, and we have to re-immunize them at, usually it's about 6 months where we're going to re-immunize our patients. We're going to monitor the other thing, because I get into infections, this overlaps, the B cell aplasia. So we see this hypergammaglobulinemia as a result of depletion of malignant and normal B cells. So this is, again, as he mentioned, it's an on-target, off-tumor toxicity. So important, they're going to be monitoring your patient's IgG level, usually for 6 to 12 months, may require monthly immunoglobulin infusions, which can be in our center. We're transitioning a lot of patients to sub-Q to get them out of our daycare, just for space and functionality. The duration is uncertain. I knew initially with the ALL population thought if they still had ongoing hypogammaglobulinemia, it was because the CAR was still working, but that's not proven. But again, really important monitoring your patients. If your patient's looking at their IgG level, looking at their risk of infection, again, your CAR tox will advise you as to how to manage that. But it can be definitely an ongoing experience. One other thing I want to highlight that we've also discovered in our area is because, again, these patients are relapse refractory, they're at higher risk for clots. Okay, so we lots of times will start our patient on prophylactic enoxaparin, either day 0, like if they come in, or if they're admitted, just while they're admitted, we will have them on enoxaparin. I'm very fortunate at my center. We have an inpatient, outpatient transplant unit. So I have a day hospital. So I have patients that can do their transplant if they have a caregiver, if they live within 60 minutes or staying within 60 minutes of our institution and they're stable, they can do their transplant as an outpatient and come in for daily visits and assessments. They also, we have that they can call at any time and come in to our either inpatient, which is in the back half of the unit, or we plop them in a bed in the outpatient and steal one of their beds. So with our CAR T, our patients, there's a lot of teaching that goes on with our patients' family and the patient, but they're given instruction sheets. Once they spike a fever, that's when they come in. But they can do part of their CAR T journey as an outpatient. So we're hoping with this Branzi, with this lower incidence, that we can get them more on the outpatient, but so far a lot of my people didn't have caregivers, so they've been inpatient. The other problem with your CAR T, of course, this became a big fury a few years ago. Then FDA reported the higher incidence of secondary malignancies, and my physician was like, these patients have cancer. They've had lots of treatments, lots of chemotherapy that puts them at higher risk. So again, they're a higher risk for myelodysplastic syndrome, bladder, and non-melanoma cancer. Part of the follow-up, Health Canada has mandated that there's a 15-year, this is a new drug, they consider it that living drug that keeps on acting, that patients should be followed for 15 years looking at that risk for secondary malignancies. So here's a patient, recent patient. I went and got some new patients for you guys. Mediastinal B-cell lymphoma. She got EPOC, high-dose methotrexate for CNS prophylaxis. She still had disease at end of treatment and referred to CAR-T because now we're second line. She was having some progressive symptoms with her mediastinal disease, so she got some bridging. And that was one good thing after initial studies, that we can do bridging now. Because I had patients, when we initially had patients going for CAR-T in the States, they'd come back waiting for their manufacturing of their cells, and they'd end up having progression of their disease and never go back for their CAR. So nice that we can do bridging. You want to do bridging that's not too intense, that causes more cytopenias and other problems before they get their CAR. So she was admitted, she had no caregiver. Because she was getting Yescarta, she was started on Keppra, and she was in a clinical trial, and she got radiation added to her protocol. So again, they're looking at if adding more lymphodepleting can add to more benefit to the CAR function in the. So she was a steady patient, so she got some tumor modulating, looking at her radiation for her treatment. Interestingly, she got it at 1 o'clock. By 1:20, so I think she had a bit of an infusion reaction or something else was going on here, because she already had a little bit of fever, had Tylenol, blood cultures, not a liter of fluid. Post bolus, her BP is still low and her pulse is up. So she got some more fluids, had started antibiotics, ECG. By that evening, her temp was 38.8. She got Toci, Tylenol, and a chest x-ray. Day 2 in the morning, everything looks pretty good. But by 3:30, her temp's 39.1, pulse 120, BP's okay. She got more Tylenol, IV fluids, increased antibiotics, urine CNS. And I didn't see in the notes, I'm sure they should have got her more Toci, I think. Day 3, her temp's 39.5. Her BP's low, so we're grade 2. She got Toci again, she got Dex, she got IV fluid bolus, she got ongoing hypotension. So again, she had Dex and Toci later on in the day. Day 4, we're still febrile. Diarrhea, all cultures were negative. Tylenol monitoring her ICE was 10 out of 10. Day 5, all of a sudden, her ICE score is 0. She's totally obtunded. She's not responding. Gave her some good old Lasix, up to 20. Stroke code was called so we could get an urgent CT. Okay. CT, there was no bleed or infarct. EEG, neuro, MRI were ordered. She was sent to ICU for observation for grade 3 ICANS with neurovitals Q1, looking at airway management and things like that. So grade 3, they're always in ICU for us. She had no fever anymore. Feeding tube was inserted related to aphasia and aspiration risks. By 1600, she was less dazed, able to follow commands, aphasic but no epileptic activity. Day 6, she's sitting up in the chair. No recall of the event. Her Dex dosing was decreased in half or more. And then day 7, she's back on the unit. She was getting Dex 10 Q12. She had some mild unsteadiness with gait. Day 11, tried to get her off Dex, but then, there was fine motor tremor, so they gave her another dose of Dex. Day 14, all of a sudden again, she's having tremors, handwriting, unsteady gait, so they gave her Dex again. Trying to wean her off. She didn't have any caregiver, and we had a really hard time with her weaning her off the Dex. She kept on having some problems and tremor, weaning her off the Dex. She didn't have a caregiver, so she remained in hospital, and she was discharged at day 34. PET shows at day 43 a decrease in size, good response. She had literally a bit of cytopenias. They gave her a couple of doses of Grastafil. Her cytopenias have resolved, and she's looking fabulous when I've run into her in clinic. no problems with ambulation. I think she just had a cane to hit the door, but she was walking around quite well and seemed to be fine. This gentleman was an interesting case. He was in my outpatient area, but day 2, he came in with shortness of breath. He did have pleural effusions prior to, but not significant, noted on pre-chest x-ray, but he came in with chills, no fever, and a little not feeling great. He was in his 60s, so they decided to keep him in. Day 4 to 6, all of a sudden he's got pedal edema, shortness of breath, AKI. Day 7, shortness of breath is increased. Now he's on oxygen. We're seeing increased pleural. Now we're seeing pleural edema. So race was called. He went to ICU. His I score was 8 out of 10. He had expressive aphasia and history of tremors. Our team instructed ICU to give TOSI, even though he didn't have fevers, but they were noticing that his CRP and ferritin were up. Okay. And he had some hypoxia. He got DEX, he got 2 chest tubes. He stayed in ICU actually 13 days. He ended up with this capillary leak syndrome. Okay. He had ascites, he had ileus, he had fever, he had delirium. They were relating the delirium not to ice, the ICANS, but more to the whole fever and the ICU, everything, capillary leak. So he unfortunately had the chest tubes for a while. He went to outpatient day 40 and was DC day 42. At day 100, he's been transferred back to his lymphoma doc for his follow-up. So the CAR-T program has handed him back. He seems to be doing well so far. So more patients are like this. I'm giving you some bad cases. We had a 60-year-old who had a history of renal transplant, diffuse large B cell, got R-CHOP, RGD-PID, didn't require any bridging, had her conditioning and self-infusion as an outpatient. Day 4, she called in at 3 o'clock. She was febrile, came straight to our inpatient area. Temp was 38. BP's a little low. Everything else is fine. Septic workup was done. Antibiotics, Tylenol, ice is 10 out of 10. They didn't do anything, just accept that Tylenol. Temperature was down. The evening she spiked again to 39.2. She had ongoing fevers. It was mostly in the evening. So they were like, is this disease or what's going on? But she was afebrile during the day, so they didn't end up giving her anything. She went back to her outpatient by day 10, and she was DC'd to clinic day 17. We usually follow our patients for 30 days more closely, and then they can go back. They'll still be under us if they're from our area till day 100. Otherwise, they can go back to a referring center. So most of our patients will require 1 or 2 doses of TOSI, and that's what you can sort of expect. So where are we going with CAR-T? Well, it's really exciting. Everyone wants a CAR. They're looking at, can we have allogeneic CARs, right? Because that waiting time, some of them, like the Breyanzi CAR, takes about 28 days to make. And you've got someone with relapse refractory. Your multiple myeloma CAR takes much longer to make. So that's an issue. Some studies talk about using multiple CARs. So, infusing, I went to one talk where they gave one CAR one day and another CAR the next day to have that dual effect going on. And designer CARs with less toxicity. We're going to start a trial now with autoimmune diseases for CAR-T. So that's exciting. Solid tumor, there's been a couple things that are seeing some better results. I know when I just went to the transplant conference, I didn't really hear anything about it. When I was last year at the transplant conference, there was distributors talking about it, where they actually now are taking a piece of the solid tumor and growing and modifying the cells and then infusing that, because what they found with the solid tumors, they were having a hard problem with the microenvironment of the tumor, that getting in and getting a sustained effect. So it'll be interesting to see, and that will impact your transplant centers, because we're going to be treating solid tumor people in the future. And also too, sorry, I didn't say at the beginning, if anyone has a question at any time, speak up. And I'm happy, as I said, to share my slides. This is just a summary of all the products that one of my pharmacists had put together. So now your bispecific T cell engagers. They're, as we had heard this morning, talking about that they designed to simultaneously bind to tumor cells and T cells to elicit that tumor direct response, recruiting and activating the immune cells or T cell engagers, blocking the signaling pathways, blocking the immune checkpoints, and forcing an association of protein complexes. So I was fortunate in Ontario to sit with a group in Cancer Care Ontario to look at how we're rolling this out. And again, now the correct term is not bispecific, it's T cell engaging antibodies, because bispecifics or BiTEs BiTEs is trademarked by the company. So the correct term. So, but we all call it BiTEs. And the interesting thing is, you have to plan and see. And there was a whole big panic all of a sudden. As I said, we had this group working on it, looking at, because all of a sudden all of these T cell engaging antibodies were coming up, and how we were going to manage it and what were we going to do. And interestingly, blinatumomab, which is the one that Amgen owns BiTEs trademark, has been around for 2014, but all of a sudden there was all of these agents. So how are you going to, and he did a great presentation talking about how you're organizing it. What are you going to do? So we're doing a lot of the same thing at our center with regards to our T cell engaging. We're looking at the patient's disease burden. We're looking at where they live, where they have a caregiver. What is the bispecific we're giving? What's the risk of CRS with it? Can we do it as an outpatient or an inpatient? And we've copied again our transplant area in that now on my hematology unit, we have a flex bed. So we have a bed, so again, that we're avoiding emergency. If a patient has an issue, that they're calling the hematologist, and then they can come in and we get an extra patient on the unit for the night. So again, how you set up and organize it, making sure that ICU is educated, your emerge is educated, having a plan for toxicity management, and then that education to everyone, because they came in hard and fast, basically. The nice thing or interesting thing with your bispecific or T cell engagers is that they usually do that ramp up dosing. So they do small little dosing at first to expose and get the body used to it. Everyone gets pre-medication, Decadron, Benadryl, Tylenol. The CRS incident ranges depending on the product, and it's a higher incidence with the IV. So the two products he was talking about for solid tumor are intravenously given. So that's where you see, and I laughed because at first he was like, oh, about, vital signs Q1H. I'm like, are you crazy? We don't do Q1H for my CAR T patients. We do Q4. So, I know the melanoma solid tumor doc, med-oncs the floor above me, and they were all in a hizzy, and I'm like, no, saying to my colleague, no, you're not doing vitals Q1 on the inpatient unit. Q4, yes, if you go in as a nurse and you find they're feeling crappy and they're not, well, I'm hoping you're going to do vital signs and look and see what's going on with your patient, but we do it Q4. So blinatumomab, as I say, it's been around since 2014, CD19. Again, we've got that marker, the tumor marker CD19 with the CD3, and we're going to induce that cell lysis. The challenging thing with blinatumomab is that it's continuous IV for 28 days. And we're actually going to see this, the indication for this has now expanded into, for our ALL population, into consolidation. So we're going to see it more and more, and we're going to see it out further, okay? Because keeping these patients in a high-risk treatment area is a little more challenging. CRS rate is low. They do all have to get Decadron before, and if there's any stoppage of the treatment for more than 4 hours, we have to re-steroid them, okay, is an important thing. So, and usually there's mandatory monitoring when you start a patient. One of the protocols has a ramping up of the dosing. Neurotoxicity can be small infection, again, when we're giving treatment, infection. The nice thing, I'm really hopeful from the future, especially now that it's in consolidation, is that they are researching a sub-Q formulation. So that's hopefully a good news story. Yes, and they're the bites. Teclistamab, we see this for your relapse refractory multiple myeloma. It's subcutaneous, which is nice. CRS rates, 72%, ICANS 3%, but hypogammaglobulinemia and patients requiring IVIG is there. So again, these aren't benign treatments, and I didn't look at all of them, but this was in one of the things that I saw. And again, really important here is that slow, gradual dosing, that ramping up of the dosing. It's given then once you ramp up, then it's given weekly. And there are looking at now, as we've started to use this more and more, looking to every 2 weeks. Progression-free survival is about 22 months. So again, I'll get into discussion weighing out your choices. Elranatamab, again, is for our relapse refractory multiple myeloma. Subcutaneous, we've got that nice ramping up dosing. CRS is about 58%. ICANS is low, 3 to 17%. Infection still a problem. Your myeloma patient also is a problem. There is talquetamab, your relapse refractory multiple myeloma. Again, nice subcutaneous. Physician can choose weekly or Q2 week with ramp up. You've got your CRS and ICANS. The other thing it has, again, it's a different target than your other myeloma BCMAs. So we do see those other off-target responses. Here we're seeing dysphagia, weight loss, skin toxicity with this one, a little different. I don't know in Quebec, is this approved? We've gotten into a bit of issues with approval. We're getting it compassionately in Ontario. But the other ones we see quite often, but this one, not yet. They're reapplying, I think, to Katha and different things. Your epicortamab, this one's for your relapse refractory diffuse large B cell. It's also sub-Q. The ramp up is quite minute doses and then a big dose. So that's where you're going to see your higher CRS is at day 15, because now I've given you a real dose. And again, infection is a risk, CRS and ICANS. Glofitamab is for our relapse refractory. It's usually can be infused over 4 hours, 8 hours if they have a reaction. It can have the ICANS. And as we talked about, that tumor flare can be an issue, infection. This one's for 12 cycles. All the other ones, you'll see it's ongoing treatment, okay, until progression-free survival. So it just continues and continues. This one also, as part of the ramp up, they give the patient a day of obinutuzumab to sort of settle things down. And then day 8 is when they get their first dose of the drug. This is IV. Right now, we're always doing this as an inpatient, okay? Infection, again, is a problem. Patients are all on prophylactic medication. They should be monitoring their IVIG levels, and they might need IVIG replacements. Education, 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 right? With all of these new treatments is so important. We saw with our immune therapies, our PD-L1s and all that, we had to educate our patients that to report to come in if you have symptoms, because you don't want to end up curing your cancer or controlling your cancer and have diarrhea for the rest of your life, colitis. Same thing here. We got to educate them about the issues and manage them. So there are a lot of different resources. Leukemia Lymphoma Site has different resources and supports. Everybody's hospital sometimes makes things, but making sure they have those supports are important. This is a patient with teclistamab. I'll just go through quickly. She was, 5th line, right? So right now, most of these are in 3rd line. She was 5th line because now it was available. She had some ongoing issues with infection throughout her treatment. She was eventually, after a year, reduced to Q2 weeks. She still had some response, but the light chains were rising. One of her first treatments, we saw that, she had a bit of a temperature, 38.9. She just got blood cultures, Tylenol, and antibiotics. She had a bit of hypotension, got some fluids, but then by the next day, temperature was fine, ongoing, and eventually then 2 years later was palliative. This patient with epicortamab, so this patient actually had a CAR T previously, then had ongoing, she also found out that she had lung cancer, but they didn't do anything about that because she had relapsed her diffuse large B cell. So she had radiation to abdominal mass. She is one patient that had ongoing neutropenia, so she was getting Lepelga every 6 weeks for her cytopenias post CAR T. With her epicortamab ramp up, so sometimes too, I wonder, right? Sometimes the docs give IV fluids prophylactically, and it's like, okay. So are we, maybe masking and not grading, things won't be as bad. So she got her Dex pre and got some throughout her treatment and did well, but then eventually progressed with her disease. This is my real interesting glofitamab case. Challenge. This lady came to us from China who had been treated in China. So she had a relapse in 2025. She ended up on a steady. And so the first day she got, so day 8 was when the first day she got her glofitamab. Day 9, she's got an unsteady gait. I-score is 9 out of 10, and she struggled a little bit with the year, but her handwriting, but my nurse gave her a 9. I would have given her an 8, but she gave her a 9. She then had a temperature, 38.9, low BP, ICE now is 6 out of 10. She got Tylenol, blood cultures, Pip-Taz, Dex. She also got, then they added methylpred. She got Tosi ×1. 11 o'clock, her BP's dropping more. Her temps normalized. She got a bolus. She ended up getting over 2 liters. Now her BP's 69/40. So race was called. She was transferred to ICU. Her I-score was then 4 out of 10. She was started on pressors, oxygen, and now, by 12:30, her I-score is 0. But at 1640, her ICE is 9 out of 10. Steroids are a wonderful thing. And she was started on Keppra by day 10, so that 2 days later, she's off pressors, oxygen. CT scan was normal. They started decreasing the decadron, and they waiting a bed on the unit. Day 11, they noted a decrease in her masses. The day 15 glofitamab dosing related to that previous reaction, she had to have it over a longer period of time. Day 16, so after the second exposure to that little bit of glofitamab, she did have that tumor flare. She had eye swelling. She had a bit of low blood pressure, got some fluids and steroids. Her I-score stayed good, and she went home on that day 17, so 2 days after. She's coming in now. She's on cycle 5. PET showing great response, and she's doing rather well with all her treatments, but just because of the glofitamab IV and the higher incidences and the issues, she's always admitted for the treatment. One of the things with your T cell engaging, lots of things with that ramp up, if you have still reaction going on, the physician can have the choice to delay giving that next dosing. And then there's protocols as to whether, there's a bigger break in it, whether you have to start the ramp up again. So one of the challenges with this woman was, how do we do an I-score? Right? So there is an article about talking about your patients with disability, deafness, different things like that, and using different tools, pictures or things to identify. Because she was on a steady and she had all these reactions, we had to go really slow with her glofitamab infusion. It's still over 8 hours. And with steady, so we actually right now, she's been getting almost 1 to 2 or 1. She's better now. So it's, the nursing ratio for her is quite, because we have to do vitals every hour and 3-time blood pressure and all this stuff. So the steady's paying for more nursing time with her. So my nurse did develop a Mandarin I-score sheet with her. Sometimes we used pictures. So there's different things. You have to be more creative. I've had some patients one day, I laughed, my nurse went in and I could hear her yelling at the patient, trying to get the I-score. He was partially deaf, and she came out of the room and she's like, okay, he's a 5. And I'm like, okay, we're starting with him being a 5. So we're looking at anything going lower than a 5, but he was I guess, a relapse refractory multiple myeloma with already confusion we were treating. So anyways, you have to go where you start from. So now the big debate is which therapy is better or which should come first, right? Should we be looking at our CAR T or our T cell engaging antibodies? So actually, I was playing with trying to get pretty slides, and AI gave me this. Um, so again, CAR T, it's autologous and requires manufacturing time. So depending on the product, my Yescarta takes 14 days to make, but I got to get it over the border and all of these things, and I wait to do my lymphodepleting chemo till I make sure Trump's let it through the border. Where your TCEAs, they're off the shelf once you got approval. So they're more available. And again, smaller centers can be using them, right? Where CAR T is only in transplant centers. CAR T is a one-time infusion. Bing, bang, we're done, right? Where this is ongoing treatment, step up doses and maintenance. Yeah. I'll finish in 2 seconds, 3 slides. The monitoring is more intense with your CAR T. With your others, it's just during that step up. Common labs looking for the inflammatory. Long-term effects, prolonged cytopenias, B-cell aplasia. We can see some of that with our other ones too. And the cost is a big thing with our bispecifics. But if you look at, I looked at just globally, I know pharmacies negotiate and hospitals negotiate the price, but when you look at teclistamab, it's about $30,000 a month. So if you're going for ongoing treatment, that adds up pretty quickly, okay? When you're looking at responses, the CAR T response outweighs your bispecifics. So, but then again, what does your patient want? What's available? Like, because if I can be treated near closer to home and not have to move and not have to relocate and all of those things, those are things to consider. With the CAR T, you have more of those acute complications. And the other thing that because I hang out with more transplant doctors, they talk about concern about T cell exhaustion, okay? Because they'd rather see the CAR be given first rather than the bispecific, because again, that ramping up of your immune system and that, I should find my notes, getting together, that overstimulation, we're going to end up with T cell exhaustion, okay? And they won't be able to lyse and break down those cancer cells anymore. So both CARs and your antibodies, T cell engaging antibodies, providing more treatment options, prolonging survival for our patients. Both have acute complications, your CRS and ICANS, more with our CAR T, as I said. It's important to have pathways to ensure safe management, and education is a key for all of our healthcare providers associated with supporting our patients and our patient and our caregiver. And I am right out of time. Oh, and go have stuff.